Hi, my name is Kristen Hockmuth, and I work in a critical care unit where patients who cannot breathe on their own are on ventilators. Because of this, they have an increased risk of developing ventilator-acquired pneumonia, which is one of the major nosocomial infections in intensive care units. There's a very simple way to prevent this, which is oral care. Oral decontamination is so important because dry and open mouth, alteration in oral pharyngeal flora, and oral inflammation allows patients' mouths to be colonized with bacteria. In a nursing survey, 97.9% of nurses confirmed that oral care tools were made available, but 88.2% of them said they thought they needed more support from the hospital. In addition, the Joint Commission adds that oral care is a necessary part of providing holistic care and effectively reduces pneumonia by 40 to 60%.
In my workplace, oral care is too often overlooked. We use chlorhexidine and have tools at our disposal, but I couldn't even find a protocol at my hospital for oral care. The importance of this oral care and the prevention of ventilator-acquired pneumonia isn't even discussed with our critical care nurses, which puts our patients at a great risk. In my workplace, oral care is too often overlooked.
Considering at least 250,000 ventilator-acquired pneumonias occur in the United States each year and accounts for 50% of ICU antibiotic use, oral care should be prioritized on my unit more than it is. Using a model for improvement that was developed by the Institute for Healthcare Improvement, I developed ways to address this concern for patient safety and health at my hospital. First, I set my aim statement, a reachable goal that we will reduce the incidence of ventilator-acquired pneumonia in intensive care units by 25% in 6 months. To measure if the changes lead to patient safety and health, we can measure rates of ventilator-acquired pneumonia in intensive care units before and after new interventions are utilized. We can also use the oral assessment guide once a day on ventilated patients. This oral assessment guide should be utilized and charted once a day on ventilated patients before and after new interventions are started, because the state of a patient's mouth can be considered an indication of quality nursing care. So, the next question is, what changes need to be made? Most importantly, an oral care protocol needs to be developed for ICU nurses and nursing assistants to follow to prevent ventilator-acquired pneumonia and provide better patient care. This oral care policy will include oral care 6 times a day or 3 times a shift, and the use of chlorhexidine 2 times a day or once a shift. Oral care tools such as toothbrushes, sponges, suctioning kits, chlorhexidine mouthwash will be made available. Also, the Joint Commission recommends using floss holders and minimal intervention remineralizing paste. Additional interventions will be included in the policy, like elevating the head of the bed and using spontaneous awakening trials and breathing trials for those who are intubated. Patients with tracheostomies will also maintain their balloon pressure between 20 to 30 centimeters and have trach care done once a shift or as needed. Once the protocol is in place, I can utilize the plan, do, study, act cycle to start small and test the protocol in a single intensive care unit in my hospital. From there, I can study its effectiveness using the previously stated measures, act on what was found, and if it was found to be effective, it can then be implemented in various ways. The new protocol and its importance will be discussed with new hires in intensive care units during orientation and have a brief demonstration of what the tools for oral care look like and how they are best used. Current hospital employees will be required to take an online course reviewing the new protocol, and there will be a short quiz at the end of the course. This would be done on talent management, and they'd receive a certificate after completion to show their managers. Oral care technique posters will be posted in patient rooms and in intensive care hallways for hospital staff to see and reference to. A hospital-wide email would also be sent out with a copy of the new protocol highlighting its importance and the date the protocol goes into effect to help its implementation into the hospital. It's clear that many patients are at risk of developing ventilator-acquired pneumonia that affects their health and safety. My hope is this policy reduces that risk and enhances quality care.